So I want to talk today about the intersection of our best clinical risk stratification tools with genomics. And I think it really follows perfectly with the two lead-up talks and the elegant presentation by Dr. Friedland talking about the mechanisms in biology underlying these novel genomic assays. So simply by way of introduction, I think it's safe to say that there's a growing attention and appreciation to the need to improve risk stratification across multiple clinical junctures or decision nodes in prostate cancer. We're increasingly attentive to the consequences of overtreatment of low-risk disease, which has culminated probably in the U.S. Preventive Service Task Force statement issuing a grade D recommendation for prostate cancer screening in general. And we're also becoming cognizant of the consequences of undertreatment of high-risk disease. So our goal this afternoon is to provide a critical assessment of whether and how a new generation of tissue-based genomic tests can improve upon a gold standard, and that gold standard being a clinical risk stratification method. These are tools that cost absolutely nothing. You get those with your biopsy. And what we're trying to determine is whether these novel tools add value to what we have already. So my overview today is to discuss why risk stratification is particularly important in prostate cancer, to understand the strengths and limitations of the clinical benchmarks for risk stratification at these various junctions, and focused really at 3 points: at the time of diagnosis, after treatment, as well as a brief treatment of the situation after recurrence. And our cardinal question is to evaluate how this array of novel tissue-based tests stack up against those clinical benchmarks. And then briefly conclude by talking about how these new tests may lead to better decisions when implemented in clinical practice. So I think really the critical picture that we need to look at to understand the epidemiology of prostate cancer is simply the incidence rate following the integration of widespread PSA screening. And as was described, essentially the incidence of prostate cancer prior to widespread PSA screening really reflected the latent manifestation of symptomatic disease. Patients who had lethal or metastatic disease or symptomatic at presentation. And if we group them together, I think conveniently these are all high-risk patients. But clearly something interesting happened in the 1990s when we started looking for PSA. We were finding, in addition to the high-risk cancers, we were finding intermediate cancers and low-risk cancers that probably never would have become apparent or clinically meaningful if never detected. So we are gaining significant insights into what underlies this clinical heterogeneity. And it appears to be what really reflects the considerable variation in clinical course. So we know that certain cancers act quite indolent and do not move and don't leave the prostate, while some tumors, even if they're small, can rapidly metastasize and result in prostate cancer metastasis and prostate cancer death. So this complexity demands sophistication and tools to assist clinicians in providing increasingly precise care to our patients, improving overtreatment and undertreatment. So these are some of the decision nodes that exist in prostate cancer, and I think these are all heavily trodden by many of us. They really begin even before a patient has a diagnosis of prostate cancer in the situation of a clinical suspicion of disease. What to do with someone who has suspicion based on PSA and digital rectal examination? Should you do a biopsy or should you not do a biopsy? And what about a patient who has a negative biopsy? Should you repeat a biopsy or should you continue to monitor them? Our focus today will really be slightly a little further down the spectrum in the interest of time, but looking at that initial management junction at the time of initial diagnosis. Is a patient a candidate for surveillance or definitive treatment? And once they've been treated, should they be considered for adjuvant therapy or salvage therapy? And even one step down the spectrum, once a patient has recurred after definitive treatment, will they necessarily require additional therapy? Because not all patients who experience a biochemical recurrence will have an obligatory metastatic event or prostate cancer mortality. So what are the clinical benchmarks? And we did discuss some of them briefly, but I want to go into a little more detail. And I always find it amusing just to enter into PubMed how many hits you get for prostate cancer nomogram. You get about 1,000 hits, okay? And it's really ramped up in recent years. And that's only that those particular terms. But essentially what those are incorporating is really a familiar cast of characters, as we discussed: PSA, Gleason score, tumor volume. We can put in T-stage, PSA density, and some other characteristics, but it's really quite familiar to all of us. What I'd like to also acknowledge is that clinical risk assessment is not a static or monolithic entity either. It's really quite dynamic. So beginning in the T&M classifications in the early 90s to the Epstein criteria, we were trying to substratify the lowest strata of risk. We moved slightly along in evolution to risk groups such as the D'Amico classifications, the AUA risk groups, the NCCN classifications, which are probably the most widely used. They're easy to remember, but they do lack precision because there is heterogeneity in those groups. So someone who's intermediate risk by D'Amico classification could be a 3-4 low volume, or they could be a 4-3 high volume. Shifting down the spectrum to our gold standard is really multivariable models, nomograms, and which incorporate quantified estimates of outcome. And these are the gold standard for today. And like I said, this is really a process of evolution, not a static picture of how we ascribe risk. And what we're ultimately trying to do is incorporate new tools into nomograms and not see them as distinct entities, but really see how they can act synergistically to improve our predictions. So to define the clinical standard, this is the early Catan nomogram predicting preoperative risk of cancer recurrence based on only 3 clinical characteristics: a patient's PSA on a continuous continuous scale, clinical stage, and biopsy Gleason score. And actually, with just sort of a very rudimentary approach, we have a fairly accurate performance at predicting 5-year PSA failure with an area under the curve of 0.79. There are other risk classification schemes which are very well reported as well. This is the UCSF CAPRA score. And this is a continuous score on a 0 to 10 scale, incorporating PSA, Gleason score, and stage, but also adding the percentage of cores positive and the patient age, which are both independently prognostic and valuable variables. So the CAPRA score stratifies actually quite elegantly by single unit changes, which are roughly equivalent in assessing risk. And this shows that we have a concordance index of 0.72 for predicting recurrence following radical prostatectomy, 0.68 following radiation, and 0.79 for patients treated with primary androgen deprivation. So these are actually quite good, but not perfect. And we're trying to add value to these tests. And these cost nothing beyond the cost of seeing a patient in our office. They are essentially free and packaged in with doing a biopsy. So we have to add value beyond what we have here. So I think we're uniquely poised to capitalize on advances in molecular and genetic characterization of prostate cancer, and we have. And they're paying dividends in the form of assays that offer risk prediction. I think we've discussed them quite extensively today, but I want to go back and ask that question sort of along each junction of clinical decision making. So the first stop is really risk stratification following diagnosis of prostate cancer. What do you do with a patient who's ostensibly a candidate for active surveillance, a patient who has Gleason 3-3 or low volume 3-4, has a favorable PSA, favorable digital rectal examination? We are trying to ascribe a risk to that patient so we can better shepherd them through the decision of treatment or surveillance. So our tool shed consists of those clinical characteristics. We can group them using T&M staging, Epstein criteria, risk groups, or multivariable models. But we're trying to incorporate new tools which have increased precision for determining who might be a good candidate and who might not be. So if we look at really sort of the grading rubric, the report card for what a genomic test might do or might not do for us, I think practically speaking, at the time of initial diagnosis, we could only ask it to do 3 things. It could tell us, does the patient actually have a higher grade or higher stage cancer that we didn't know about? And that would render the patient a poor candidate for surveillance. And there are tests that do that. Could they predict the risk of progression on surveillance, right? So suppose the patient's disease state is actually genuinely low risk and low grade today. Can we predict, based on a molecular signature, who will develop a higher grade cancer or a higher stage cancer over time? Or alternatively, could we assess downstream risk of disease metastasis or death from prostate cancer based on one static snapshot from a biopsy? And it's important to recognize that even though our clinical models did pretty well at the time of diagnosis for patients being treated with surgery or radiation, they're actually not calibrated to tell us who's going to do well on surveillance. So if you try to apply the Catan nomogram or the Stevenson nomogram or even the CAPRA score to tell us who's a good candidate for surveillance, who's not going to progress on biopsy, who's not going to reclassify on biopsy, it's actually quite meager, not much better than a coin toss for the base Catan nomogram, and also about AUC of about 0.63 for the CAPRA score. And why might that be? I think the clear explanation is the patients who are ostensibly candidates for surveillance are a relatively homogeneous group. They're virtually all Gleason 6. They're all low PSA. They're all clinical stage. So it's hard to distinguish amongst that group because they all do pretty well. So I'll run through some of the genomic assays that have been applied in the prostate biopsy space. So as Dr. Friedland mentioned, and we look at one of his validation papers of the Prolaris assay, the Prolaris score was an independent predictor of biochemical recurrence for men treated with external beam radiation in a racially diverse cohort with a hazard ratio for biochemical recurrence of 2.1 in a multivariable model. The Prolaris test has also been applied to patients treated with radical prostatectomy, where the Prolaris score is an independent predictor of the risk of biochemical recurrence and metastatic progression. And essentially what it's doing is substratifying risk even among patients with a characteristic Gleason score, finding differences in molecular profile even in patients who have Gleason 6 tumors, Gleason 7 tumors, Gleason 8 tumors. An additional assay which we have spoken about already this afternoon is the Oncotype DX genomic prostate score. This is a quantitative RT-PCR signature looking at gene expression levels that's done on manually microdissected tumor tissue from needle biopsy. As mentioned, we're drawing on distinct biological pathways which were selected and refined for multiple endpoints, enriched for biochemical recurrence. And this test is optimized for very small tissue inputs, less than a millimeter of tissue. So what they're doing is attempting to substratify risk even among clinical risk categories. So if we look at a patient who has a CAPRA score 0, the lowest clinical risk that we can really appreciate, these are patients who have Gleason 3+3 tumors, PSAs less than 6, young patients, clinical T1C on examination, there is a fair degree of variation that appears to exist. Conversely, in patients who are CAPRA-4, who are sort of on the higher end of intermediate, these are patients who might be Gleason 3-4, higher PSA, or older patients, there is still a variation in risk. So on this rainbow plot, you can see that there is a degree of, there are some patients who even, although clinically ostensibly have a higher grade tumor, have a more favorable genomic profile, and perhaps these patients might be candidates for surveillance. So the endpoint that this has really been calibrated to is predicting adverse pathology at prostatectomy. Adverse pathology defined as high grade, Gleason 4+3 or higher, or high stage disease, clinical T3A or node positive disease. And sure enough, the GPS score is an independent predictor of adverse pathology at prostatectomy, with an odds ratio per 20 unit increase in GPS score of 1.9. Even when adjusted for age, PSA, clinical stage, and biopsy Gleason score. On decision curve analysis for predicting high-grade and high-stage disease, strategies incorporating the CAPRA score and the genomic information at higher threshold probabilities appear to yield higher net benefit. So they were more valuable clinically in predicting who had higher grade or higher stage disease. To slide slightly down the scale, the next step along essentially the next stop on the train in terms of treatment is patients who've already been treated and trying to determine who is at higher risk for developing an adverse event after treatment. So I think we're also fairly familiar with this clinical decision node as well. So a patient who's been treated with radical prostatectomy has clinically adverse characteristics, and we're trying to determine who is a candidate for adjuvant therapy and who's a candidate for salvage therapy. Historically, the tools we've had to mobilize and attempt to understand this essentially draw on the patient's preoperative PSA, their Gleason score at surgery, lymph node status, margin status. And the question we're trying to ask is, can genomics add value to that prediction and help distinguish who is likely to recur, who is likely to metastasize, and who is not, and who can be spared adjuvant therapy? So the clinical tools that we have in this domain include tools, multivariable models, including the Stevenson nomogram, which actually perform quite well in predicting biochemical recurrence, with a concordance index of 0.79 to 0.81 in training and validation sets. These multivariable models also predict the outcome of salvage radiation with a concordance index of 0.69. So these perform actually quite well. So we need to beat this gold standard, we actually have to add a fair amount of prognostic information. Another multivariable model which is frequently employed is the CAPRA-S tool. So this is distinguished from the Stevenson nomogram. This is a readily tabulated tool where points are assigned for each of these unfavorable characteristics. And so it can readily be calculated on demand. It does not require a calculator or a computer to do these calculations. And in an external validation in the search database in patients treated with prostatectomy, the concordance index was 0.73. It outperformed the Stevenson nomogram on calibration plots and decision curve analysis. So these two tests, I think, indicate that a multivariable model does represent the gold standard or the benchmark for comparison. So the cell cycle progression score was initially evaluated as a predictor of biochemical recurrence following prostatectomy. This is a study of archival formalin-fixed embedded tissue from UCSF, over 400 patients who were treated with prostatectomy. We were trying to determine the risk of developing recurrence. The combination of the CAPRA-S score and the cell cycle progression score improved the predictive ability beyond CAPRA-S alone, indicating that the genomic information added value beyond the post-surgical CAPRA score. On decision curve analysis, which we mentioned it to be really a graphic representation of how this might impact clinical decisions, there was a modest benefit to adding the cell cycle progression score to the clinical information. And what this figure is visually trying to depict is which strategy will offer the highest net benefit. So we want that line to be the highest on the y-axis. So we can see that the yellow line represents the combination of the clinical and genomic information, and the red line represents the CAPRA-S score alone. So basically purely on the pathologic and pre-op clinical characteristics, who is likely to recur. So interestingly, at the extremes, patients whose decisions are unlikely to be influenced by any information, it doesn't matter. And that makes sense, because if a patient is not going to be treated no matter what, there's no reason to order a test. And if a patient wants to be treated no matter what, it probably also doesn't make sense. But in the intervening segment, there appeared to be value added by incorporating the genomic information. The GPS score has also been evaluated as a predictor of recurrence following prostatectomy. This is data from 2 U.S. military medical centers showing that the GPS score was an independent predictor of biochemical recurrence after treatment. So similarly as it was in the active surveillance space, it was an independent predictor with a hazard ratio of 2.65 when adjusted for clinical characteristics. So other tests also inhabit this space. I think we heard an excellent depiction and description of the Decipher classifier, whose methodology is distinct from the other 2 assays that we discussed. It represents genes implicated in proliferation, cell migration, and adhesion, tumor motility, androgen signaling, and immune system evasion. So we are getting a more comprehensive genomic picture using the Decipher classifier. It's validated as a predictor of metastasis following radical prostatectomy, and truly outperformed all of the clinical and pathologic information among even high-risk patients. And so this is a cohort of over 1,000 patients treated at the Mayo Clinic who had PSAs over 20, Gleason scores of 8 or above, T3B, or had a clinical nomogram predicting metastasis of over 10%. So despite this high-risk subset, we could still substratify risk, and the genomic classifier had an area under the curve of 0.79, so it really performed exquisitely at predicting who would develop metastasis. So this has been employed to ask the question of who might benefit from adjuvant therapy, and we can see how far we got from the clinical information alone. So the CAPRA-S, we're using that as our gold standard for clinical risk prediction. had a pretty modest area under the curve of 0.66. And the genomic classifier alone performed really quite beautifully, 0.83. So there was only a modest benefit of adding that clinical information to the genomic information. So briefly to step one inch beyond that spectrum, among patients who have experienced biochemical recurrence after treatment, and we're trying to substratify who is at greater risk for developing metastasis, and therefore who could be treated and who could not be treated. This is a paper looking at only a small cohort, only 85 patients retrospectively, but these are patients who had biochemical recurrence after radical prostatectomy. But nonetheless, the Decipher score could still stratify men who would develop metastasis versus those who wouldn't. So if you had a Decipher score that was low, only 8% developed metastasis versus 40% who were high. So theoretically, a patient who had even developed biochemical recurrence, who had adverse pathology, we could substratify their risk for developing an adverse event. And I think that's pretty clinically powerful. We also briefly discussed the Porto score, so that's using the similar Decipher platform methodology, but this is actually a distinct 24 gene expression signature predicting response to radiotherapy. Like I said, it's distinct, so it outperformed the Decipher 22 gene classifier in predicting who might respond to radiotherapy. So I want to end briefly by mentioning the question of how these genomic tests function in our hands. So we can develop and validate tests in academic cohorts that appear to work beautifully. They can do well in validation cohorts, but the real ultimate question is that of clinical utility. Will they help us make better decisions for our patients? I don't think we're that, so we take that with a grain of salt because I don't think that the data that we have to present here actually answers that question. There are studies that have fallen into favor of examining how people change their decisions based on these tools. But they offer, I think, perhaps the first glimpse at how these might be implemented. And this is a study done by Dr. Crawford looking at physicians who are using the cell cycle progression assay. And they essentially surveyed them and said, did you make a different decision based on this information? So overall, using the cell cycle progression assay, almost 2/3 did notice a change in what they thought they were going to do and what they actually did. So about a quarter of patients were moved towards intervention, and about 37% were moved towards a non-interventional strategy, suggesting that there is really a clinical difference when you get this information. This has similarly been shown in the Oncotype assay, where there was a significant increase in the utilization of active surveillance in NCCN very low and low risk groups, saying that even though you take patients who are the lowest risk strata that we can identify, low and very low risk, the results of the genomic tests appear to kind of move the needle and help us push patients more towards surveillance. Perhaps they increase our own confidence, perhaps they increase the patient's confidence, but it's beginning to ask that question. So I'll stop there and conclude by saying that these new tools are tasked with exceeding and not simply meeting the performance of clinical risk prediction benchmarks. So it's not enough to simply meet the gold standard, you have to beat it. Genomic tests are meant to work with clinical information and not appear separate. So in almost all these situations, the genomic tests act synergistically with the clinical information to offer better predictions. So several tissue-based gene expression tests appear to offer improvement in relation to gold standard clinical tools at several junctions, at diagnosis, after treatment, and even in the setting of clinical recurrence. We still have remaining questions about clinical utility, cost effectiveness when implemented on a broad scale. But these tests are increasing in market share and utilization, and we're also almost every month receiving information about a newly validated or tool which might be coming down the pipeline. So stay tuned.